Welcome to the pharmacology class, and today's topic is antimycobacterial drugs. And antimycobacterial drugs are used to treat the diseases caused by mycobacteria. And mycobacteria are a specific type of the bacteria that have a different cell wall, and it has a mycolic acid in its structure that leads to some differences that prevent it from staining with the gram stain. And also when the acid is used to clean the gram stain, then these bacteria uh, cannot be fast uh, uh, cannot be the dye cannot be removed fast with the uh, removed with the acid, and that is why they sometimes called a fast acid bacteria. And that makes them hard to identify because they are not stained with the gram and require a specific stain and also a fluorescent microscope to observe because the stain is fluorescent. And also they require a specific treatment because normal antibiotics are not effective, and usually the resistance is high. So the two classes of the antibiotics are used to treat the disease, and moment, Mustafa is also here. Mustafa, welcome to the lecture. And
Hello, sir.
Hello, كيف
there are
شلونك؟ منور.
two lines of the
Rafi sir, we say in Arabic, welcome to the lecture, منور. It is like a short and a good.
how number.
منور. منور, it is mean like what? Mustafa, why you are laughing? No, I'm serious.
Number, right?
No, منور by the meme, starting with M. منور.
Number. Okay.
Yes, it's like that. So it's see, in place of saying welcome to the lecture, مرحبا بك في lesson. It is take a long. It's like too long. So for make it short, we just say منور.
I like marhaba more, but since
مرحبا, it's like hello, but
anyway, I like
welcome.
marhaba more, so I
Yes,
will
yes.
use that one.
You
So
can use it مرحبا, yes, but how
okay.
to say that? مرحبا, it's mean hello. It's like when I told you hello.
Okay,
But if I say, uh, well, as you said, welcome
Bahar,
to the lecture.
I have to remind you that this lecture will be published online. So
Yes, 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 yes. It's not a
okay,
problem. I just saying that is this our Arabic word, so we all
okay.
know it.
I'm not sure what is the Arabic, but
You
most of
can
the
find
lectures
it. Just
begin
I
with
can
the
send it to you.
Alhamdulillah. So, and also from the some lecturers start with
You
um,
can ask Ala and Bushra. They know what is mean.
uh,
Mnawar.
also the
Where is Ala and Bushra, by the way? Ala,
most
Bushra, why
lectures
they are not answering?
most lectures in Arabic countries start with the Bismillahir Rahmanir Rahim, and
Yes, but this is too long.
okay.
It's for starting, but for speak with
Okay,
somebody,
thank
we
you very
say
much,
no.
Bahar. I will take that
You're welcome. You're welcome.
into
I
next
appreciate
time I
that you
will
are.
try to use that. So if I don't forget. So
But where is Ala and Bushra? Why they are not in the lecture?
they are. So let's continue with the
I'm
lecture, and there are
here.
two drugs. So the first line and the second line. So first line drugs are include ethambutol, isoniazid, pyrazinamide, and rifampin. So these are four drugs that are used to treat the tuberculosis or TB. And tuberculosis has two phases. First is the latent phase, and latent phase is when uh, there is no any symptoms, and it's called LTBI. So LTBI is a latent phase, and then active tuberculosis is another state when the patient has the symptoms, and this is the when the most of the cases are diagnosed. So, but at this state, the patient is contagious, and that is why it's important to diagnose tuberculosis in latent in LTBI. So the uh, first line agents are used, and then second line agents are used when the first line agents are not effective. Uh, so there are uh, two types of infections. First is the LTBI, that is latent tuberculosis infection. So TB stands for tuberculosis. So tuberculosis is TB, and active disease is a active tuberculosis or just TB. The TB is the primary cause of the death in the world, and that results in about 2 billion people infected, and uh, in, the also new cases of non-tuberculosis mycobacterial infections are started to increase. That includes the Mycobacterium avium intracellular, Mycobacterium chelonae, and Mycobacterium kansasi and fortitum. So, and also Mycobacterium leprae that causes leprosis, another disease, is common too. Then so there are no drugs developed for the non-tuberculosis infections, but some antibiotics that we studied during the previous lectures and classes are effective against non-tuberculosis mycobacteria or NTM infections, non-tuberculosis mycobacteria infections. And for the tuberculosis, it's growing slow and requires treatment for several months or even years. And LTBI, that is latent tuberculosis infection, can be treated for 9 months with isoniazid uh, or, um, or with a 12 once week doses of isoniazid and rifampin in combination. So, but the active tuberculosis must be treated with the several drugs. It's usually 4 drugs regime that is lasts for 6 months, and the treatment is multi-drug because of the resistant tuberculosis or multi-drug resistant tuberculosis. So, and usually the treatment is about 2 years. So this is a long treatment. So the standard short course chemotherapy for the tuberculosis includes isoniazid, rifampin, ethambutol, and pyrazinamide for 2 months. This is the intensive phase, and then it is followed by the isoniazid and rifampin with for 4 months. So this is a continuation phase. So Like intensive phase, we use 4 drugs, it is short, and then continuation phase is only isoniazid and rifampin, and it is longer, it is 1, 2, 3, 4 months. So complete treatment is 6 months. So these 4 drugs are used for the standard therapy, and when started, the susceptibility data can be obtained, and then depending on the susceptibility to different agents, the treatment can be replaced. So the second line treatment for the multi-drug resistant tuberculosis is usually include aminoglycoside like streptomycin or kanamycin or amikacin, and also capreomycin. All they are used parenterally, like with the injections, and also the treatment includes the fluoroquinolone. It's it's a levofloxacin or moxifloxacin. Moxifloxacin is more popular, and uh, the additionally the cycloserine, ethionamide, and para-aminosalicylic acid is used for and for the very resistant tuberculosis. Also, linezolid is used sometimes. So, and because of the large amount of the drugs and the adverse effects are also very intensive, and the treatment is half year, and that is why the patients don't like this treatment. So the patient adherence is low, and to increase the better patient's compliance, to increase the patient compliance, so patients don't comply much, is a directly observed therapy, that is DOT. That stands for directly observed therapy. That means that patients take their medications while being watched by the nurse or doctor. So this approach improves the cure rates, and most hospitals offer the DOT services. Isoniazid is one of the most important anti-tuberculosis drugs. The mechanism of action of the isoniazid is activation of the mycobacterial catalase peroxidase, and then that allows isoniazid to be metabolized from the prodrug to the drug, and isoniazid uh, um, inhibits the enzyme that the tuberculosis used for the synthesis of the mycolic acid, and that leads to the inhibition of the synthesis of the mycolic acid in the cell wall. So the cell wall is lacks mycolic acid, and that is why it will not be very tough, and then the bacteria will die because of that. So the isoniazid is only used to treat the tuberculosis, and also only for the mycobacteria, and that is why antibiotic spectrum is only mycobacteria, and most bacteria are resistant now to the isoniazid. So the isoniazid is mostly effective against the intracellular bacteria. It is absorbed after oral administration, and the fat food decreases the absorption. And also the isoniazid undergoes N-acetylation and hydrolysis, resulting in inactive products that are excreted later. And usually all patients are divided to two groups: rapid acetylators that acetylate the isoniazid in 1 hour, and slow acetylators that acetylate it 3 hours or even 4 hours. So, and slow acetylators will excrete the non will excrete the less inactive isoniazide and more active isoniazide. And action can be prolonged in those patients. And the adverse effects include hepatitis, and usually it is unrecognized, and sometimes it can lead to the death. So that is why it's important to check the liver frequently. And also if the patient drinks an alcohol, then the liver damage can be potentiated, but in Muslim countries alcohol is contraindicated because of the death penalty, so that is why not a problem. So the second adverse effects is neuropathy. And neuropathy, it is usually seen in the hands and feet as the feeling of the numbness, and this adverse effect is due to the deficiency of pyridoxal. This deficiency can be avoided by supplementation of the pyridoxal, that is vitamin B6, and that however, the vitamin can decrease the efficiency of the isoniazid. So the central nervous system adverse effects include the convulsions, especially in those who are prone to the seizures, and hypersensitivity reactions are seen as rashes and fever. So probably the bushra for you is contraindicated for that purpose because of the hypersensitivity. And also the isoniazid can inhibit the metabolism of the phenytoin and carbamazepine, and that can lead to the adverse effects that caused by that drugs, and also in case of the phenytoin can lead to ataxia and death. So the second drug is rifampicin, like a group of drugs, rifamicins include rifampin, rifabutin, and rifampin. So these group of the antibiotics. They are used orally, and rifampin has a broad antimicrobial spectrum and can be used to treat for many infections. And mechanism of action is block of the RNA transcription by uh, inhibiting the DNA-dependent RNA polymerase. So that is used to in the RNA transcription. The antibacterial spectrum include the Mycobacteria tuberculosis and also other mycobacteria, including Mycobacterium avium complex. So that is actually in AIDS. And also many gram-positive and negative microorganisms that caused by the meningococci or Haemophilus influenza. And other types of the mycobacterium like lepra are also susceptible to the rifampin. The absorption is good after oral administration, and the rifampin can induce the hepatic metabolites like the isoniazid can decrease the if isoniazid will decrease the metabolites of uh, the metabolism of the drugs in the liver. And the rifampin vice versa will increase the metabolism, and that will lead to a decrease in the effectiveness of all these drugs, including the HIV drugs, antiviral drugs, methadone, that is a painkiller, is opiate, like a morphine, oral contraceptives for the oral hormonal contraceptive that women use to for family planning, the prednisolone, that is anti-inflammational drug, propranolol used as antihypertensive drug, quinidine is antimalarial, sulfonylureas are also antimicrobials, and warfarin is anti anti-clotting drug, so drug that prevents the clotting of the blood. So these are all drugs. Concentration of all drugs is decreased, and efficiency also decreases when combined with the rifampin. Then the adverse effects include the nausea, vomiting, and rash. So usually there is no death or hepatitis, and but these are only seen in older patients and alcoholics or those with a chronic liver disease. The flu-like symptoms can occur, and mild diarrhea, sometimes renal failure, and hemolytic anemia and shock. Then rifabutin and rifampicin are actually uh, same same drugs, and usually are used in some HIV patients and uh, patients with LTBI, that is latent phase in some HIV patients. Then pyrazinamide. Pyrazinamide is a synthetic and is used with the combination with the isoniazid and rifampin and ethambutol. The mechanism of action is unclear and supposed to be enzymatic. The pyrazine is active against the tuberculosis that is in lesions and macrophages, and also the liver toxicity as previous drugs, and usually drug is effective during the first several months. Ethambutol is a bacteriostatic and is only used for the tuberculosis, and adverse effects include the neuritis and color and discrimination can be seen and should be tested. So alternative second line drugs include streptomycin and the streptomycin, para-aminosalicylic acid, and capreomycin. Also, fluoroquinolones, macrolides are used for the treatment. So this is tuberculosis. And for the leprosy, that is the another disease that is not common now, but it was common when like about 30 years ago. It was very common, but now it's not as common because it can be effectively treated by the dapsone and rifampin. But in some countries, like African countries, it's still common. So, so it's about 200,000 diseases every year. So the dapsone is actually, so the leprosis is very uncommon. So, and this is the way it looks like on the patient, and this is the same patients after treatment during the half year. So the mechanism of action of the dapsone is inhibiting the dihydropterase synthetase, like all the sulfonamides, and that is that leads to the bacteriostatic effect for the Mycobacterium leprae, but also dapsone is used for the treatment of the pneumonia caused by pneumocystis jirovecii in immunosuppressant patients that are the HIV patients, because pneumocystis jirovecii is not seen in normal patients because it's not pathogenic for the patients with a normal immunity, but in immunosuppressed patients it can lead to the death, and that is why the dapsone is used for the treatment, and also the clofazimine is used for the treatment of the leprae, Mycobacterium leprae, and this is a dye that mechanism is not completely researched, but still it's effective combination, develop some discolorization of the skin, but that is reversible after the treatment is stopped. This is the mycobacterial drugs. So antimycobacterial drugs. That is all. What are your questions? So if no questions, then thank you for marhaba for attending lectures, and see you next week at the lecture. But please stay after the weekend.
Thank you, sir.